Hi, I'm Erin Rasnake, physical therapist in the Acquired Autonomic Dysfunction Program at Children's Hospital of Philadelphia and primary author of Exercise for Postural Orthostatic Tachycardia Syndrome, Challenges and Opportunities to Improve, published in the January 2026 issue of the Cardiopulmonary Physical Therapy Journal. On behalf of the author team, including physical therapist Dr. Kristen Kouvel from the Armellino Center of Excellence for Williams Syndrome at CHOP and Penn Medicine, Dr. Sarah Cooper from the Acquired Autonomic Dysfunction Program at CHOP, and Dr. Elliot Greenberg from the Sports Medicine Physical Therapy Division of CHOP and the University of Pennsylvania Perelman School of Medicine, we appreciate the opportunity to share this clinical perspective paper with you. This manuscript reflects many years of work with adolescents presenting with acquired autonomic dysfunction, also known as dysautonomia. Postural orthostatic tachycardia syndrome, or POTS, is the most widely recognized form of dysautonomia. POTS symptoms can be diverse, but often include, in addition to orthostatic intolerance, fatigue, palpitations, brain fog, headache, gastrointestinal disturbance, and temperature dysregulation. Declines in exercise tolerance and functional mobility often follow, leading to deconditioning, negatively impacting participation in school, work, and social interactions, and ultimately diminishing quality of life. Females of childbearing age are predominantly affected, with a female-to-male ratio of 5:1 and a median age of diagnosis of 13.1 years. Prevalence of comorbidities is high in individuals with POTS, including long COVID, mast cell activation syndrome, myalgic encephalomyelitis/chronic fatigue syndrome, or ME/CFS, hypermobile Ehlers-Danlos syndrome, and hypermobility spectrum disorder, among others, reported in the literature to exceed 80%. Many patients meet criteria across multiple diagnoses, so screening for these conditions and making any needed modifications to the treatment plan is imperative to mitigate potential negative impacts on symptoms and function. In particular, ME/CFS and associated post-exertional malaise, or PEM, should be top of mind for PTs caring for individuals with POTS, as patients with these conditions are at high risk of increased disability if exercise is too aggressive. In fact, graded cardiovascular exercise has been found to exacerbate symptoms and potentially trigger further functional decline in persons with these comorbidities, and thus is no longer recommended for this subset of patients. Non-pharmacologic means of management are prioritized for treatment of POTS, particularly in adolescents. This includes exercise training involving graded cardiovascular training and core and lower extremity strengthening in conjunction with increased fluid and sodium intake, physical countermeasures, sleep hygiene, and behavioral health support. Also in this group is wearable compression to manage the common phenomenon of venous blood pooling. While there's no universally agreed upon exercise protocol to treat POTS, the Dallas Protocol and Modified Children's Hospital of Philadelphia, or Modified CHOP protocol, are often used by clinicians. Detailed descriptions of these protocols are included in the paper. In both of these protocols, individuals gradually increase cardio training duration and transition from supine or recumbent positioning, regarded to be imperative, at least initially for many POTS patients, to upright. Like many other providers using these protocols, over the years, our group at CHOP has encountered significant challenges with clinical use. Starting cardio duration in both the Dallas and modified CHOP protocols ranges from 18 to 40 minutes. Target heart rate values guide exercise intensity, with Dallas calculating specific heart rate numbers and the modified CHOP using target heart rate ranges based on age-predicted max heart rate. We observed a large portion of our patients struggling to meet training timeframes and heart rate targets, and reporting symptom exacerbation both during and after exercise, leading eventually to further functional decline. These individuals also experienced often increased anxiety and heightened somatic hypervigilance as they struggled to attain or maintain target heart rate numbers, further derailing their exercise sessions. On the other end of the spectrum, some less debilitated patients found that recumbent exercise lacked the intensity required to produce a training effect. Compliance with exercise programs was frequently negatively impacted across the spectrum as a result, with many patients reporting frustration due to lack of symptom or functional improvement. To address these issues, we examined our means of assessing and prescribing cardio exercise duration, intensity, and position, understanding that a customized approach to exercise based on individual need might be more successful. Using extensive literature searches, chart reviews, and our clinical experience, we developed the CHOP AADP exercise determination tools. The CHOP AADP mode of exercise tool uses a point system to help recommend recumbent or upright positioning based on patient presentation, including presence or absence of recent syncope, blood pooling, excessive tachycardia during orthostatic testing, symptom occurrence during submaximal aerobic testing, and self-reported disability on a patient-reported outcome measure. Patient safety is paramount, and clinicians are urged to use their judgment alongside this tool. Clinical judgment is also advised for cases in which PEM and/or significant anxiety impacts participation in exercise. Starting cardio duration recommendations are based on submaximal aerobic testing. At CHOP, we use the YMCA 3-minute step test as it's clinically feasible, requiring minimal equipment and space. 1-minute recovery heartbeat count values associated with fitness levels for ages 10 through 25 years can be found in the suggested duration tool alongside our experience-driven recommendations for starting timeframes. This paper includes the CHOP AADP recumbent and upright exercise guides as supplemental digital content. The recumbent program starts at 2 minutes, while the upright starts at 10 minutes, but again, an individual's entry point is flexible and is based on testing. Each works gradually towards tolerating upright training for 45 minutes, with cardio sessions occurring 3 to 5 times a week. A 0 to 10 rating of perceived exertion scale to guide intensity is used in place of target heart rate parameters to reduce somatic hypervigilance and increase focus on function. Strength training recommended 2 to 3 days a week is included in the exercise guides, with positioning recommendations also based on the mode of training tool point-based assessment. Clinicians are encouraged to customize strengthening exercises according to an individual's specific needs. While the CHOP AADP exercise determination tools and exercise guides have been developed for use primarily with adolescents, they are structured to be easily applicable to an adult population as well. At CHOP, we're using them successfully with patients who meet POTS diagnostic criteria and with those who present with significant autonomic signs and symptoms but fall outside those criteria. While further research is necessary to evaluate the efficacy of this program, it will help clinicians improve the standardization of care for this population using objective tools and evidence-based interventions for exercise prescription, tracking progress, and improving clinical decision-making. Thanks so much.